Welcome, everyone. It is so nice to see you. It's so nice to be face-to-face with you. So many of you we spend hours and hours talking to on Zoom or by email, and so to see your whole person is really exciting. It gives us so much energy. We really appreciate you taking the time to hang out with us today. My name is Julia Dobbins. I am the Director of Medical Respite at the National Healthcare for the Homeless Council. I'm so happy to be with you today. Later this summer, I will be celebrating 11 years with the council, which is pretty unreal. Thank you. Thanks. 7 of those years have been spent specifically on medical respite care, which translates to literally hundreds of hours on the phone with people like yourself who are either working in respite programs or working to develop respite programs. Before I came to the council, fresh out of grad school, I worked for the Tennessee Coalition to End Domestic and Sexual Violence. I spent a lot of my time in that job driving around rural parts of the state as a baby social worker, sitting with mostly women who worked in domestic violence shelters and sexual assault centers, trying to figure out a way to support these folks doing really difficult work with really few resources. And as I've been reflecting on my decade at the council, I've been thinking that it turns out that my career and really my life's work is focused on how to support people who are doing really important work. And I take a lot of pride in that. I think there's a lot of expertise that I've built in that, and yet I have never worked in a medical respite program. I spend, I would say, 90% of the oxygen that comes out of my lungs is about medical respite, but I haven't actually worked in a program. So a lot of the council's medical respite work over the last several years has leaned heavily on the Respite Care Providers Network, the RCPN Steering Committee, who really are our experts in the field. And we do still lean on them a lot, but these are folks who have full-time jobs, many of them more than one FTE that they're managing. So really our medical respite work changed when we launched the National Institute for Medical Respite Care in the summer of 2020. And when we did that, we made the bold decision to finally start a medical respite team at the council. And I'd like to introduce you to that team now. For folks in the back, there are some seats up here. It's a little tight, but we're glad to have you. So this may seem unrelated, and that's because it absolutely is unrelated, but I am currently taking an astrology course because I'm turning 40 this summer and I'm trying to round out my personality a bit. And so all I think about these days is either astrology or medical respite, and the two are starting to fuse a little. So I'm going to introduce you to the medical respite team from an astrological lens. So there are 4 primary elements in astrology, and I know I've lost half of you. You're like, astrology was not on the agenda. I understand, bear with me, I promise this will be quick. There are 4 elements in astrology. That's fire, earth, air, and water. And the medical respite team really benefits from having 3 earth signs on our team. Earth signs are considered to be grounded, practical, good listeners. They care about aesthetics, and Taryn Below, who is our newest medical respite team member, certainly embodies those qualities. Taryn joined us in February of this year. She's based in Portland, Oregon. She's bringing a much-needed Pacific Northwest vibe to the medical respite team. Taryn was actually at this PCI last year. She and her colleagues in Olympia, Washington started a medical respite program. So if you are in the process of starting a medical respite program, find some time today to talk to Taryn. She's literally been in your shoes. Samantha Marco is also one of our earth signs. Samantha is based in West Virginia. Samantha has been with us since September of last year. Yeah. Samantha came to us from West Virginia Coalition to End Homelessness. Samantha is our editor. Samantha is organized. She has a critical eye. She seems to be one step ahead all the time somehow. Samantha really cares about doing things well, and she wants things to be done correctly, and that is reflected in all of her incredible work. Our last earth sign is Stephen Wilder. Stephen has been with us for 2 years now. Stephen is based in Nashville, Tennessee. He is a social worker. He comes to us from Room in the Inn, which is a homeless services agency, shelter, medical respite program in Nashville. I consider Stephen our professor. Stephen is a muller. He mulls over things. He thinks, he sits, he processes. He never speaks without thinking, which I think is an incredible quality to have that I would like to emulate more. He's an incredible writer and researcher. He's great with technical assistance. Stephen is also, little known fact, our resident rock star. Stephen plays the bass and the stand-up bass and occasionally can be found touring with a band. The medical respite team also benefits from having 2 air signs on our team. Air signs are known to be creative, lots of ideas, community connectors, interested in communication and community building. Krista Signor is one of our air signs. Krista's been with us for a year and a half. Krista is based in Tulsa, Oklahoma, and came to us from Austin, actually, from the Continuum of Care, COC in Austin. Krista is a recreation therapist, so if you are trying to figure out what type of programming you want to set up for your medical respite program so folks are not just staring at each other all day long, talk to Krista. She can help you with that. Krista was recently named the president of birthdays at the council because Krista is unbelievably considerate. She is the walking embodiment of teamwork, and if there's something she can do to support her team or the KP cohort that she manages, she will do it, and that spirit really elevates all of our work. Caitlin Sinovic is our other air sign on our team. Caitlin has been with us for 2.5 years. Caitlin is based in Florida, and she previously worked at the Baltimore HCH, so she knows this city very well. She's an occupational therapist and has provided clinical care inside the clinic and also in the medical respite program. Caitlin is our resource creating machine. 95% of the resources that have been created since NIMARC was started have been created by Caitlin. And that's not just because she's a great writer, which she is, or because she's just so productive, which she is, but I think Caitlin is also fiercely dedicated to ensuring that people have the tools they need to do their job well. Every time I talk about Caitlin, the word fierce seems to fall out of my mouth, and I think it's just because it's the best way to describe her. Caitlin was the first staff person to make a medical respite team, and in many ways how the team is and how the team functions is because of Caitlin. I didn't totally know what I was doing when we started the medical respite team. I still don't always know what I'm doing, so Caitlin's partnership in this work has been incredible. This little medical respite team does really great work. I'm really thrilled to work with them. I am the team's singular water sign, and with much love to all the water signs in the room, I think one water sign on a team is probably enough. We bring a lot of feelings to the space. Noticeably, we do not have a fire sign on our team, but I will say Barbara DiPietro, our Senior Director of Policy, who will be speaking to you in just a few minutes, is a fire sign, and I feel confident that as soon as she starts speaking, you will think, that woman embodies the energy of fire. I'm really proud of this team. I'm really proud of our medical respite work. This team is creative, hardworking, an unbelievably silly group of folks, and it is truly one of the joys of my life to work with you. Thank you. So I mentioned earlier the Respite Care Providers Network and the RCPN Steering Committee. The Steering Committee is made up of about 15 representatives from across the country who are our experts in medical respite. They're our connection to the field, and they really guide the Council's medical respite work. And the Steering Committee is led by Brooksand McKinney, who is the chair, and Susanna King, who is our vice chair. If you're interested in joining the Steering Committee, please come talk to me. Nominations open in January. We're always looking for more representation from across the country and specifically interested in consumer voice, folks who have had the experience of being a client in a medical respite program. So I mentioned NIMARC, which is the National Institute for Medical Respite Care, which was launched in the summer of 2020. And NIMARC is an institute within the council, and this institute really benefits from the expertise of the RCPN Steering Committee, the Medical Respite Team, and other folks on council staff like advocacy, policy, research, clinical folks. One of the primary focuses of NIMARC is building community partnerships in the effort to continue to develop medical respite resources. And we're really thrilled with the amazing partners who have come to the table to help build medical respite capacity across the country. Some of the things we've been able to accomplish since we launched NIMARC is first, we are engaging with 57 programs or communities who are developing programs in community cohorts. Those community cohorts involve one-on-one TA and monthly or bi-monthly peer networking calls. As part of these projects as well, we've been able to re-grant over $6 million directly to medical respite programs for capacity building, adding staff, expanding their services, building their EHRs, revamping a room, whatever it is that they need. A lot of our partnership work is working with folks and funders to help them understand the impact of medical respite and why they should be investing in medical respite care. We've expanded our work across California. California is the first state in the country to make medical respite care a reimbursable service through Medicaid. First, but not the last. North Carolina is right on their heels. Washington State right on their heels. Illinois, Michigan, several states are following suit. So what we're learning in California, mostly the hard way, is how to do it well and maybe how we would not want to replicate it in other states. And so what we're learning in California is helping us, I mean that with so much love to California, so it's helping us advocate around Medicaid reimbursement for medical respite in other states. And then finally, this is very exciting. When the steering committee first finalized and published the standards for medical respite care in 2016, the goal was always what comes next from here. Are we going to seek some type of accreditation, certification? It is very complicated to figure out a certification process for medical respite because every program is very different. But we are moving forward with the certification process. We are field testing it this summer. We're really excited about it. And so more information will come this fall. Okay, so that's my spiel. Let's talk about today. So today we are focused on starting a medical respite program, all of the components that we need to start a medical respite program. The agenda for today is based off of a resource, our program planning guide, that we'll make sure that you get after this training. But we want to walk through the primary components, the building blocks for starting your program. There's a lot of folks in here who are new to respite and a lot of folks who are not. So there's all different levels of expertise in this room. So again, I encourage you to talk to the folks at your table. We're going to be talking about hospital partnerships. We're going to be talking about designing the space. We're going to hear from some folks who are in the process of developing their program and how they've set up their planning. We're going to hear from a provider panel. We'll have time in the afternoon for some discussion, from some group discussions, and then this afternoon, in true middle school style, we're going to do movie time with a snack while we watch some virtual site visits and then hear from representatives from those sites to share a little bit more about their programs. So as medical respite continues to grow in popularity and starts to become a little more mainstream, there are new folks coming into the medical respite field who have never really seemed interested in homeless services before. And so we are excited about that and also cautious about that. And so one thing that we care very deeply about is ensuring that this growth of medical respite is really grounded in the philosophy of care of medical respite and healthcare for the homeless. And the center of that is patient-centered care, client-centered care, trauma-informed care. And so we want to start the PCI every year with the voice of folks who actually have the experience of being in a medical respite program so that we don't get too far removed from what it is we're trying to do, why we want to expand respite, why we want to fund respite, why we want to evaluate respite programs. So I'm going to invite Caitlin up to introduce our first two speakers. Thank you.
Good morning. I'm really excited that we have Tony and Sarah who are joining us from Joseph's House in Washington, D.C., who made the treacherous commute up this morning. If you're not from the area, it's not as easy as it sounds to get from one city to the other. But Tony and Sarah, please come on up. And they are community members from D.C. who have worked with Joseph's House. So.
Hello, everyone. I want to thank for introducing me. I'm here representing Joseph's House. I've never been a patient of Joseph's House, but I've seen the work they've done. It's a loving, caring place. It gives hope to people who's given up. I've seen miracles happen in Joseph's House, and it's a place that I'd rather perish in, if I should say, because the love they give you is as if they're the ones that's suffering, and how they would like to be treated if they were changed, if they were in different situations. Joseph's House is a very, very different place. It's a loving place. As soon as you step across the doorsteps, you feel the love. the care that they give the residents there, the help they offer people. And all you have to do is just ask. Simply just ask. They helped me get my birth certificate. I was born in Paris, France, so I had to go to the State Department to get my birth certificate. They helped me get that. Helped me get my ID together, my Social Security together. They made me whole again as a person, right? Now, mind you, it's a respite/hostile place, hostile place, because I've seen people pass away in there, right? And the way they treated them, they gave them the hope that you're going to be okay. They love them to their last breath. I'm telling you, I've seen it. I've seen miracles happen. I've seen people come in with one foot over the cliff and the other one on a banana peel. I've seen them get them up and walk and get them into places of their own. You know, I've seen miracles happen in there. I really do. And I express everybody to come, just check it out. Just come visit and see if it doesn't change your mind. I think if I knew about Joseph House 4 or 5 years before I actually knew about Joseph House, I would have been in Joseph House a lot longer. But it didn't happen that way. I met Miss Patty. If anybody knows Miss Patty, she's a very instrumental part in my life because I met her at let's say, a recovery place, and she used to come there every Thanksgiving and holidays, and we set it up for her and stuff like that. Through Miss Patty, I have an apartment today. You know, she gave me an apartment. And a building that was renovated that was full of people that they put in hotels to renovate the place, and they had the first choice of apartments when it was renovated to come back. There was 2 empty slots, and since I met her 2 years before that, a couple people didn't come back, but they left the vacancy for me, and she got me in that place, right? Where would I be without her? Or Joseph House, as a matter of fact. I'd probably, who knows where I'd be? I'd probably be somewhere, but Joseph House gave me hope. I mean, I've always had hope. As a matter of fact, believe it or not, I am now, I found out recently, I'm the ambassador of Joseph House. The ambassador of Joseph House. And the plaque says, I go above and beyond what I'm supposed to be doing up there. But I don't believe that. I believe that I'm giving back to what was so freely given to me. You know what I'm saying? It was just the love that I expressed is the love that was given to me when I first got there. Miss Patty, since I was never a patient there, she introduced me to Joseph House and told the staff there to make me family. What did she go and do that for? She made me family there. Now, Miss Patty had moved on. She moved up to Boston to take care of her mother, but she left another caring person named Kashara, who she tutored to take over her position. Now, mind you, Miss Patty was there for like 30 years. So Kashara has some big shoes to fill, but she's doing a good job of it. And I can't overexpress my feelings for Joseph House because it's helped me, and as it's helped many others that I've encountered that's come through there, you know. The staff is phenomenal, but the volunteers come and stay for a year, and then they leave. But I've seen so many volunteers that I get sad when they have to leave, but they have to pursue their own careers. So the flux of people that I've met in Joseph House lets me know that it's working. It's working. I met a lot of beautiful college kids that come in and volunteer, they give them themselves, and do the same thing that staff does when staff gets too swamped up with all the clients there. There's not many clients there, but the ones that are there, they're very important. And the love that the volunteers that work there know that they're important to us, and that they make it important to themselves to treat them as best they can. And that's the beauty of Joseph House. Everybody really cares for everybody, right? Now, I know I just know that it involves me, but it's not about me anymore. It's not about me anymore, you know? I lived in the world of suspended animation for so long that I was the ruler of the castle. I reigned supreme, but not in Joseph House. Quincy Jones put it best when they made the record, We Are the World. Leave your egos and attitudes at the door. And when you walk into Joseph House, that's exactly what you feel when you walk into Joseph House. Wherever's bothering you or wherever you think you are, you have to leave it at the door. Because you'll come in there and you get instantly humbled by the situations that are there that could have very well as easily been any one of us. Any one of us. At a turn of a dime, we could end up at a place like Joseph House. But I hope if this does happen, you do end up at Joseph House. Because there's no place better I can, to my limited knowledge of respite homes, this is my first encounter with a respite home, but the love that I felt, that I wish all respite homes was like this. If it was, the world would be a better place, even for the dying, what they do to make the comfort, live to the last breath comfortable and loved. And loved. I'm serious about love thing. This love thing is not overrated. It is not. And love, to me, Joseph House, it permeates love. You know, love. You can't help but love the situations that you see other people in. You also have to have the ability to love them because they know for any given second, it could be you. It could be me. You know? And if I have my last breath, that's where I like to leave it at Joseph House. They have a memorial for people who passed away there. They get the families involved. They Zoom the families and have the families meet, have everybody talk about the families, members to the family, how they affected our lives. Oh, wow, it's a beautiful place. It's a beautiful place to let them know that the people who passed away, their family members or friends, that they were loved. Let them know, put their mind at ease. You know, because some of the people don't make it to see their family members die or pass on. But we shower them with love. We really do. And love's a healing thing. It really is. Now, being the ambassador, let me go back to that. I love that. I'm the ambassador of morality. I keep the morals, the spirits jovial, fun, you know. Life is not all bad. Situations are terrible, but there's fun in situations, there's learning experiences in situations. And it's just an overwhelming place. I've never experienced anything like Joseph House. I've been to a lot of houses, but none quite like Joseph House. So I can't help but impress upon everyone in this room that hospice house or respite house should be like Joseph House. It really should. And I encourage everyone in the room to just visit. Just take a time off and come visit for about an hour and a half, and tell me what you think about it. Being the ambassador, I'd like to know. But anybody that needs to know about Joseph House, please give us a chance. Give us a visit and find out for yourself. That's me. That's all I have to say about Joseph House. Now, I can go on and on about Joseph House, but I think there's other people that need to be talked to. Thank you for letting me share.
Okay, my name's Sarah. I'm a current resident, actually, but this is my third time being there over the past 4 or 5 years. I'm going to back up. I'm originally from St. Petersburg, Florida. I've been HIV positive since I was in middle school, since the early 90s, so for about 30 years now. So I'm a long-term survivor of HIV, which was much different back then. I was on the West Central Florida Ryan White Planning Board there, and I never heard, I had been homeless in Florida. I'm not going to say it wasn't existent where I lived, but I never heard of it. At least not through Ryan White or my own experiences. I moved to DC about 5 years ago. I became homeless again. I've also struggled with drug abuse most of my life in cycles. And I first went to a like a drop-in center, just like to try to get a change of clothes and, eat, normal things that you kind of like monopolize the whole amount of time being homeless, where you're gonna sleep, where you're gonna eat, where you're gonna get a clean change of clothes, and where you're gonna keep any belongings that you wanna keep, or if you do wanna keep them at all, if it's gonna be worth the effort, And the doctor at the drop-in center referred me to respite care at a homeless shelter, and which was a blessing, because then I was able to, not think about those basic needs, because those were covered, and able actually to get into medical care, case management, and other things that I otherwise was not a priority for me. Be able to get some clothes and keep them. While I was there, I was hospitalized, and I actually found out about Joseph's House on my own, kind of through following the money from Ryan White in that area and through kind of Google. And I had to have a referral to go, so I got the case manager in the hospital to refer me. They were an extreme help. I've been there 3 times, like I said. The first time, I actually relapsed before I was able to get housing. So before I was able to get housing, after a certain amount of months, I did get healthier. The second time I went, I did stay until I got housing. I completed that. I kind of like fell off the wagon after a while as I became more disconnected with Joseph's House. And it was during COVID, that was during COVID. So even when I was in the house, as much of a support it was still kind of isolated because we couldn't go anywhere or have any visitors, of course, because everyone was immunology, immune, had weak immune systems, whatever that term is. You know what I mean. So, but they've been an extreme benefit. They do everything they can, though, within, the scope of protecting the residents and, within, what they can morally, support. Walks, outings, connections with services. I'm actually, when I came back this time, I still have my apartment that I got last time I was there. I just came in for 90 days, which is almost over. But I wasn't taking my medication on my own. My immune system was like down to almost nothing. I had multiple infections internally. My apartment was not livable because I hadn't cleaned it for months, because due to sickness and pain that I was in. So since I came back this time, they've helped me clean it. They've gotten me, stable, my health stable. I'm actually working part-time now, which is taking a lot out of me, but it's really important to me to be able to feel productive. So even when I wasn't working, I try to help around the house as much as I can, because just that feeling it gives to be able to be, productive, even to give back or to help others, which is really important. And you're not required to do anything in the house, which is really nice. Like, there's no assigned chores, but it's welcome. Like, it's kind of like, as much as you can feel good to do, like, they really praise it and support it, you know what I mean? Which is nice. Which is really nice, because a lot of people aren't able to, but when you can, it's not overlooked it's not overlooked, which is nice, which is really nice. Yeah, but they helped me clean my apartment since I've been there, to make my apartment livable. They got me connected with the cleaning service once a month when I go back, so just in case I don't fall into that cycle again. Because I didn't even want to be in my own house. It was getting so bad, let alone to be able to rest. I couldn't even rest my mind, let alone the pain in my health, but just because of my surroundings. And yeah, my health is stabilizing. It's really been a blessing. And because I don't have family in DC, like the love that Tony spoke about, it's really true. It's like, when you go there, it's like going to mom's house. Like with family, like we sit around and play cards, we play music, have dances, might do karaoke. It's like almost like visiting mom's house. It's like the place where you always feel welcome. No matter what's going on, you can be honest. You don't have to you don't have to hide like any mishaps in your life. Everything is like kind of like unconditional love, which is really nice. Respite care, yeah, that's pretty much all I have to say. Without respite care, you can't even think about care. because you're so preoccupied with the basic needs, the basic needs that you're not even thinking about, like you can't even think about a lot of the basic needs like medical, because it's like I need to like eat, sleep, and clothe, you know? And my life, I wouldn't be standing still, honestly, I don't believe, without respite care. I mean, I would have, because my immune system just goes on the ground when I'm in that survival mode. When I'm in survival mode, it's like I'm just trying to survive. And I really believe I still wouldn't be living today if it wasn't for having respite care available to me. And I just wish more people would have that. But that's all for me. Thank you.
All right. Good morning. I am a nervous speaker, so I definitely have notes. All right. My name is Krista Signor, and yes, that's written down. So, yep. My name is Krista Signor, and I'm a medical respite program manager with the council. This morning, as previously mentioned, in our first session, we'll be discussing funding a medical respite program and relationships with hospitals. And in a moment, it'll be my privilege to introduce our two subject matter experts who will lead us through this topic. Before turning it over, I'd like to first take a moment to point out some great resources on our website and provide some quick level setting. Although there are many great resources to note, the main resource I'd like to point your attention to at this time is the Relationships with Hospitals online course located on the Learning portal on the NIMARC website. You can see it here. This free online course was developed from hours of listening sessions where we interviewed medical respite programs and partnering hospitals across the nation. In this course, we answer the following questions. How do hospitals and medical respite programs work together? Who should medical respite care programs build relationships with? And what are some successful strategies for engagement? And many more. So we definitely hope you'll venture over to the Learning portal and check it out. Now for some level setting. Okay. Why are we starting our morning talking about building relationships with hospitals? Well, hospitals and medical respite program relationships are incredibly important for a host of reasons and can be mutually beneficial. Hospitals look to medical respite programs to provide a more appropriate placement for recovery, linkages to community and housing resources, assist in reducing their lengths of stay and readmission rates, and ensure they are following laws and policies that prevent hospitals from discharging clients without a safe plan or location. On the other hand, partnering with local hospitals presents opportunities for medical respite programs. The benefits to partnering with hospitals include having a consistent referral source, potential funding, streamlined communication, system improvements, opportunities for innovation, and many more that will be discussed today. Let's take a moment to be really honest, though. Whether you're receiving funding or not, it's up to all of us, medical respite care programs, FQHCs, COCs, and community service providers, to build a relationship with our local hospitals. As you may already be aware, across the country, post-acute, unhoused community members are regularly being discharged to places not meant for human habitation, to the doorsteps of emergency shelters and medical respite care programs, or in some cases, just to the sidewalk out front. This is not to blame or shame hospitals. Often individuals that go into hospital management do so because they want to provide the best health care possible and make a positive impact. Instead, this is to name the reality of the situation. The most important reason we're talking about developing hospital relationships this morning is for the safety, well-being, and dignity of our unhoused community members. Although there can be challenges within this relationship is a critical piece to medical respite care and ultimately disrupting and ending the cycle of homelessness. Whether you have a relationship with your local hospital system or not, community members are still being discharged somewhere. So let's talk about how we can be a part of the solution. Finally, I'd like to name that we could spend the entire day, week, maybe month or year talking about developing relationships with hospitals. But with so many important pieces to cover today, the speakers are going to do their best to cover as much content and answer as many questions as possible. No pressure. If at the end of this session you still have questions, please feel free to join the small group conversation later today where the conversation can continue. With that, let's get to it. I did write that. Let's get to it. Nailed it. All right. It is my absolute privilege this morning to introduce two subject matter experts and genuinely wonderful human beings, Brooksanne McKinney from Cone Health in Greensboro, North Carolina, and Lori Nelson from Center for Respite Care in Cincinnati, Ohio. Thank you.
Okay.
All right, look at
Well,
us.
let's
Okay.
introduce ourselves first. That's me on the left, Roxanne McKinney,
Yeah.
and that's my daughter, Brooklyn. And last time I was at the conference, she was a little baby, and now she's all big and 4 years old.
Yeah. Oh, okay, yeah. I'm Laurie Nelson from Cincinnati, and Julia, you'll be interested to know that I am not only an air sign, but an Aquarius sun and moon, which means I might go off into the weeds, which is literally my happy place. But I'll bring it back around, and we're going to be moving quickly and providing a lot of information. Do we have to click ourselves? There we go. So here's our agenda. We're going to run through really quickly, setting the stage. So Roxanne is going to give you some information, some high-level information. Then we're going to kind of get into the meat. I just have a question really quick. Can you raise your hand if you are getting ready to start a medical respite or you've just started a medical respite? Excellent, because we got a lot of that level information. So I'm going to turn it over to you to do your part, and you got to do this. Okay.
All right, so first of all, my name is Roxanne McKinney, and I work for a hospital system. And no, I'm not evil just because I work for the hospital system. But I actually started with the council in 2007, and I was trying to see how many, that's 16 years, right? And when I first began, I had just started as a director of medical respite program in Raleigh, North Carolina. And to all of you newbies around here, when I first showed up, it was like I met my family. And so just know that your time here is so valuable. Like when I think about that many years ago, I've met Sarah Chambrone, all the other dinosaurs. There's Jordan right there. I'm seeing everyone now, and I didn't see y'all before, but it truly is a family, and I just really appreciate just this time to get together, especially as I roll off my time with the RCPN. But I think really what's important with going into the hospital system, I started on the outside. I did housing, case management, and then a respite program, and then went into the healthcare system because I knew that's where the people were. And I knew that I wanted to go in there and change things and try to influence the hospital system to invest in respite program. That's what I'm doing now for Cone Health, but it's taken 5 years for it to even possibly get funded. So just know that it's a hard struggle, even if you work for a hospital system. But also due to COVID, it really halted a lot of funding. And coming from dysfunctional North Carolina, you will understand why the politics also get in the way of things. And I really want to stress that the hospital system, just because there's standards, there's regs, there's all these things, but you will always have a relationship with them. So remember that. So anytime you talk negative or whatever, just remember that you have a relationship with them. And someday that may come back to bite you if you talk negative about the hospital. So I say that just in the sense of knowing there are really great people that on the executive side, even though a lot of people think it's bad, I know that for myself, every day I sort of question, especially now, why I work for a hospital system, because it's very bureaucratic. However, there's leaders there that really care, and they're the ones that really want to change, and it just takes one executive to see what's going on, and you may get funding. So just remember that one story, and I think that's getting back to why we're up here, is just saying, how do you relate to the hospital? So you have all the regulated programs from the CMS standards, the metrics, Joint Commission, Population Health Management, and then that was the note that I just talked about with funding opportunities. They're important, but the discharge protocol is what's critical for quality care. And the more that you can get inside, like working with the social workers and really seeing what's going on, you can prevent that next patient that's being rolled out to the bus stop in a wheelchair. I mean, that's really what it comes down to. And I feel like my position, I'm in a system level job, and I am on these daily difficult to place calls. And most of my time now is just preventing someone from being discharged back to the street when they, if you're trying to get into a SNF, group home, beds are taken, they're all full. And so respite is that solution. But I know for a fact almost every day
we hear the nursing homes say that if they're homeless, if they have a behavioral health issue or if they have a substance abuse issue, they cannot come into their facility. So I'm sitting there saying, why not? And also trying to get the resources, but I think really that's where we're at now. Like, I feel like 5 years ago, it was not this bad. Now it's really bad. And so whatever you can do to help the hospital out and get the education, and say this is why respite, when it comes to standards, and the next, you push right here, okay. Why is that right there? Okay. Okay, so it's sort of out of order, but with the ACO and social determinants of health, I'll have to go to social determinants of health. We all know that respite addresses all the SDOH needs. We know that because you do transportation, you do food insecurity, you do housing, utilities, interpersonal safety. We know that we address those things. So when you're relating to the hospital, that's what you always think about. Say, hey, this is your selling point. This is what we do. And the latest CMS regulations, and this is an example of the EMR discharge summary in the hospital, by next year, every hospital is going to have to prove that they screen for SDOH and that they actually have a referral resource out in the community. So they're going to have to, so if Joint Commission or someone comes in, they're going to have to pull up their records and say, hey, this person was discharged here, this is the resources that they received. And you actually have to prove the resource platform that you're using. So in North Carolina, we have this new platform called NC Care 360, which does direct referrals to the nonprofits. And in the 1115 waiver regions, those nonprofits are actually getting invoices and revenue from the 1115 waiver due to the platform. And we're hoping that will expand. Barbara, 1115 waiver, we're hoping to renew and expand because as Medicaid expansion hopefully still happens in North Carolina after the budget, this whole topic of discharge is going to be more in the trend because they're going to want to have a place for people to be discharged, but also to address all these things. So as respite addresses the social determinants of health, it also addresses the discharge issue when they're going to have to prove to CMS that they did go somewhere besides just a shelter. They're going to be asking more and more questions about that. Because I know at our hospital, and I have to catch all the discharge planners with this, they will put down the address to the shelter as their place of discharge, but it's a day shelter. It doesn't even have beds at night. So I have to go in and say, hey guys, you can't do that. So that's why a lot of times on these calls I tell you about, a lot of people hang up when I get on the call because they know that I'm going to say something about it. So people either love me or they really hate me. So this right here, this is the discharge summary, and see all the SDOH interventions. They are going to have to be shown to CMS, and this is where you can really fit the gap in services for the hospital system. So that's our whole thing, is like just starting to think about how you can approach them, not just for discharge, but also for funding opportunities in the future. Yeah. Yeah.
All right. Yeah, I know. 'Cause I don't think So, hi again. Once again, I'm Laurie Nelson. I am in my 10th year with the Center for Respite Care, and I know he's going to roll his eyes and laugh, but I have the honor and privilege to work with Dr. Bob Donovan, who is actually like an icon among all of us. And we are celebrating our 20th year of providing medical respite services in Cincinnati. And I'm going to talk to you a little bit about community benefit. So some of you are probably familiar with this, but all hospitals as part of ACA are required to have a community benefit plan. It is important to their tax exemption, and it also is important to their community and the services they're providing to their community. So what this entails is going to be everything that is pertinent to the community that the hospital is in, and how they are going to address the community needs. And you should be able to find this within 1 or 2 clicks of a hospital website. That's actually a requirement, but I don't I didn't check that, but I don't think you can get it in 2 clicks, but you should be able to find it. And that's going to give you a lot of information about what your community needs are, and then what the hospital plans to do to focus on that. And that's going to be important for you to set the stage for what you want to present when you're approaching the hospitals. Let's see. I think that covered that. Okay. Oh, this one's yours, though, ACA. Okay, yeah, I'll go forward. Okay. So I'm going to talk a little bit about approaching the hospitals and kind of what we did, because this has been an ongoing thing over the 10 years that I've been with the center. It ebbs and flows. Sometimes we have great connections and great relationships, and then things change, and then we have to start over from the beginning. But I've, over the years, put some things in place that have made that process easier and have actually made a continuation of those relationships versus starting over. So I'm going to talk a little bit about how you make your case. So you really want to, before you ever approach, you want to make sure you have really detailed information about what your program or treatment vision is. So what's practical? And I researched the NIMARC models of care. So that's some work that the Respite Care Providers Network has been working really hard on over the past couple of years, I think. And what we've done is narrowed down or sort of helped to categorize 4 different types of medical respite. So I recommend you go out there. I'm not going to get into that too much. There might be something on it later. And, but you really want to know what your program or your treatment vision is. And then what is your demographic? Who are you going to serve? So that goes without saying. There are medical respites that include families with children. There are medical respites that just do single moms. So you need to know who you're going to serve so that you can let the hospital know. And then what kind of tangibles? So if you're just starting out, you probably don't have any statistics about your clients, but you can find enough. There's plenty of data on the National Healthcare for the Homeless Council's website, and you can get statewide data that's required. You can most likely get a lot of data from your community. And then if you do have a medical respite functioning, or you're part of a shelter system, there's probably a lot of data you can get. Have that ready. And then one of the things we did most recently, and it was actually with work we were doing, hi Chester, with MCOs recently. So we've been negotiating with Humana to be a referral source for us. And there was a lot of confusion on their part about what we did for their members coming out of the hospital and coming to our respite program. So what we did is we put together a very detailed treatment narrative. So we started at the moment of referral, and we went through a typical case all the way through, talking about length of stay, what kind of services we would provide, how we would determine case plan initiatives, all of those things. And it turned out to be a really great resource. And not only, we did it specifically for a managed care organization, but then we ended up using it for some hospital conversations, and they were very appreciative of that, because you're going to encounter people who are going to be very confused about what we're doing and what kind of services we're providing. And if you can give as much detail as possible, you're going to get that in much quicker. And then resources that are available. So what community partners do you work with, and what kind of services will they have, what kind of wraparounds and community supports will they be exposed to and then have access to through your program and then after discharge. And then what is it going to take, what will clients gain, what is it going to take for successful completion? Now, the Center for Respite Care, we do an individualized case plan. There are a minimum of 3 goals. This is created together with our case managers and the client, and they are developing their own goals, and our measure of success is if they meet more than half of those, so 2/3 of those goals, we consider that successful if they make it all the way to discharge. Some of the things we put in there standard are health management skills. We call it personal health literacy. So we're making sure that the client understands their condition, chronic and acute, what they need to do for that condition, what kind of medications they need to take and when, because we've had clients come in and take all of the meds that they get for a day in one fell swoop. And so it's educating those individuals on how to take their medication and why it's important. We talk a lot about why this is important for things like diabetes. That's probably one of our number ones, where we're talking about testing your blood sugar, managing your blood sugar, and taking your medication or your insulin as directed because it's important for your health. And then establishing a medical home, that's always a primary goal. You want to help them establish the doctor they're going to go to. And this will be more important when I get to more about the hospitals. And then assistance with stable placement. We call it stable placement because it's what's best for the client at the moment. Now, our community would consider an apartment the only thing that's stable placement, but we are saying what is most important. So we see clients going into substance abuse treatment facilities, mental health facilities, assisted living facilities, nursing homes, and unfortunately sometimes hospice. But we're making stable placement, which just means they're going somewhere stable, they're not going back to the street. And of course, some of our clients go to apartments or halfway houses. That happens as well. But a medical home or a stable placement, it should always be a primary goal. And be prepared to talk about the benefit you will provide to the hospital unrelated to funding. And I'll tell you why, because I'm going to tell you a little story. When I first started with the Center for Respite Care, I had a big meeting with our primary hospital, the University of Cincinnati Medical Center. And I was meeting with the CEO. And I walked in with all of this data about how much money we save that hospital every year. And I went through my whole spiel, and that CEO looked me right in the eye and she said, "It's not a dollar for dollar comparison. That's not a good argument for us to fund your services." And I had no backup plan. That was awful. That was one of those lessons learned, and I'm sharing my pain so that you guys can avoid this. Don't do that. Yeah. So you have to be prepared to have other things that you're going to provide to that hospital. So, and we'll get into those. We'll get into some of those other things. But 3 directions you can go, and all are valuable. And they can be done simultaneously. So how we've approached is, obviously, social workers and care coordinators. This is your first call, because you are going to, those are your primary referral source. They are the ones desperately looking for placement, because the hospitals know they are not to discharge to the street. It happens, but they're not supposed to do that. So there's a lot of pressure on the care coordinators and social workers within the hospital. If you can get a meeting with them, and they usually have like standard trainings that you can be a speaker at, that happens for us a lot. And we always bring treats. Bring treats. I promise that will go a long way. And then, of course, the administrators, you need to get up to the top as well, because these are the decision makers. These are the people who are going to clear your program for accepting their referrals. And also, if there is funding involved, and we'll get in that in a minute, and I'm kind of flying, I know. They're going to be important because they are the decision makers about funding. And then, of course, the foundation. So we just went through this with Bon Secours Mercy in Cincinnati. We had a connection to the foundation, but we want an operational agreement. We want the C-suite individuals to know who we are and know what's happening. So we've approached in all 3 directions with Bon Secours Mercy, and I mean, just a couple of weeks ago, we got the commitment for $50,000 a year to fund our program. And it's necessary because we all know, there's never enough funding. So making the approach, the 5 degrees of Kevin Bacon, of course, avoid the cold call if you can. You know somebody who can get you in front of these people. Utilize your health foundation, utilize any grantors that are medical based, your board. One of the biggest things that I've had is physicians on my board have the ability to walk into a hospital administrator's office and say, "I want to see so-and-so," and they get in. I cannot do that, but they can do that for me, so they pave the way. Don't go in cold, because like you'll see down here, be patient. You will probably have to call several times. You will attend lots of meetings with no results. And then the players will change. So that has happened a lot, especially among the administrators. And then you need to be diligent, direct, and polite, and do not give up, because you will get there. So getting an agreement with the hospital, getting to know the hospital gets to know you, does not always directly relate to funding, but it could. And that might be part of the conversation, so be ready. So we put together a bunch of funding models. Talk about what services you want to be paid for and how much it costs. So bed nights, meals, medical care, get all of that together and come up with some basic rate. You can do all in, meaning everything it would cost for you to provide a bed night. And then in what manner? Lump sum, like because I get $50,000 a year, just lump sum from Bon Secours Mercy. Flat rate, so we have an agreement with another hospital where they pay us so much money per client per month. Only covers 10 days of care, but I got my foot in the door and we're gonna ask for more. And then per diem, so we know exactly what it costs us per day to provide our services, and so we use that approach quite a bit. And then when do you wanna be paid? Monthly, quarterly, yearly, that's simple, or per day. If you have somebody in my bed tonight, I'm sending you a bill tomorrow. Just be prepared for that. It may be a couple years down the road when you have some statistics related to that healthcare system of the clients or patients that you've provided services to. Use that data. And then be flexible with that too. Take what you can get, because once they know how great you are, you've got a lot more leverage to ask for more. So after you get funding or you get this relationship established, you gotta keep your data. So also I talk about going to the outcome measures and data collection resource that we also created through the RCPN and the Learning Collaborative. So that's a great source of basic information. It goes through easy data to very complex data, but my advice here would be get it as comprehensive upfront as possible. I've learned from experience that when you have to add something later, it's a lot of work. So and I'm happy to share what we collect because it is everything and we analyze the crap out of it. So be very thorough with what data you're going to collect, because you never know when somebody's going to throw something at you and then you got to backtrack. So some of the suggestions, of course, demographics, days of service and bed nights, we actually break that down by hour as well. So hours of care, our cost and what goes into that cost. We're very lean and we're happy to share that information with anyone. And then discharge. So one of the best statistics we ever did was we would break it down by hospital and show who came in and where they went and the percentage of success, which is somewhere near 70 for us, which is great and amazing, and very powerful information that we take back to the hospitals. And then ask for regularly scheduled meetings. I finally got my agreement with University Hospital, and we meet quarterly, and we talk about everything that has happened in the past quarter, and now we have this ongoing agreement and relationship that has not had these ebbs and flows and starts and stops, and I highly recommend. Okay, I'm going really fast. Oh, this is you.
Okay, so she spoke about a lot. So I don't want to repeat anything, but I will add this whole thing with data, because I know people are like, oh, it's so hard to get data from hospitals. Very true. Even if you work in the hospital, it's hard to get data from the hospital. But there usually is a data analyst that, if you have some type of sharing agreement, I would say to focus more on that pre and post discharge days, because I know going back when I was in Raleigh, I would meet monthly with the hospital, and we would show how many days they were 6 months pre and 6 months post, and just so that percentage. So if you get caught in this cost things, because there's actual costs and that's charges, and that's why hospitals will get sort of like that response, just because you may go in there and say, hey, this is how much money we saved, and they'll come back and say, actually, it wasn't $1 million, it was only 10,000. So you just don't want to approach them saying that. But if you can show those pre and post days, but also they are going to have that data person. So if you have someone that there is a sharing agreement, they can actually look up the names, and you could show when they got into respite care, and then they can look at percentage as it decreased. Just recently, I was trying to do a return on investment, they call it like a pro forma, and they looked at the Z codes of the homeless individuals that were in the hospital last year, and they could actually look at days that were extra that they stayed in when they needed to be discharged, and they did the calculations of all the nursing staff that it cost for that time period. And so it came out to 1.5 million in return on investment, and I'm saying I just want 300,000. So just, so I think just being really creative with that, but if you can find the data guru, you can they can be hidden in the hospital, but once you find someone that can do that, it can really help with those pro formas and return on investment. And this, like the readmissions are a priority, medical home, focus on primary diagnosis. We say that as well, because if you have someone that has, comes in and they come in for another need a week later, then in your data, you may have an outlier of someone that can ruin the whole return on investment, because they may come back and have surgery and stay for a number of months. So make sure that when you look at the readmission, if it's a different diagnosis, that you make sure you track that, because they will question that as well. So it's all about relationships and collaboration, finding a champion, have your data ready to approve. Invite administrators or executives to your site. I don't want to say cold call, but you can call and just invite them. But also being involved with your continuum of care and inviting them there, so they see that this is a larger thing, more than just respite, but that you're working with all the COC agencies. That shows that you do collaboration, and that also when someone needs a place to stay, even from the discharge side, the social workers know to call you, and also you can help with other agencies. Try to recruit hospital staff to your homeless coalition or COC leadership. Try to get them on the board for the COC or your own board. But the more that they can hear the stories, they will then relate to discharge solutions. Yeah, asked about community benefit. She talked about community benefit. Just know community benefit is different for different hospital systems. Ours, the last hospital system I worked for was a grant-based one, but here at Cone, it's an internal process. So you really need to make sure that you know what their process, because you may have to do an application, or you may need to meet with the CMO or the head of the community benefit department. High utilizer meetings are internal, but sometimes they do have community members come in, especially for those ones that have a signed release. And so if you can be a part of those high utilizer meetings, then that shows that you have that relationship, but also it gives an option for discharge for respite and possible funding. Already said, get involved. City council, stakeholders, yeah, get involved. With care coordination, with case management, a lot of times if you meet with the discharge planners, and she talked about going to those regular meetings, but also they have lunch and learns. But just remember, I've done this before. I went to lunch and learn, you have to bring the lunch. Don't show up without lunch, because then they may not listen. And just trying to support discharge planning, and we're getting the 5 minutes. And so we'll probably go into questions. You want to do that? Yeah, there we go. All right.
So yeah, we provided a lot of information, and I know it was fast, but find us, we're here all week. Find us, and we're happy to talk to you more in depth about anything, but we do want to get to some questions. So I know we flew through that, but we're willing to discuss it further if anybody needs.
I'm just curious. Is it working?
Sorry.
All right. Anyway, thank you. Sherry Downing, coming in from Montana. I am wondering how great a percentage of the folks that you're treating for medical issues also have behavioral health disorders? Because that's what I'm hearing around the country, is that that's significant.
Well, I would say personally, probably 95%, just because just being homeless is traumatic, and so that's what I always state when I'm asked that. However, it's interesting if you look at hospital coding, a lot of times they have to be assessed by a behavioral team usually to get that diagnosis, and a lot of times they're not even assessed for that. So a lot of times you may have to advocate for that, just because there's sometimes not funding. Like, we don't have a psychiatrist that goes up on the floor and does assessments per se in the hospital. But I do feel like the more that you can have those resources on site in your respite program, like we had a mental health respite in Raleigh where it was when the institution would discharge, they would have a bed for 30 days. And that really allowed the advocacy for medications and make sure they had an ACT team and possibly a housing voucher. So there's ways to work with that, especially with more behavioral health side of thing. But like I said, I think what they usually say 25% or something, but I would say 95% just due to the trauma and all the other things that go along, especially when someone becomes homeless. So.
Hey, Julia, we have a question up here.
Yeah, right.
So, my name is Richard Johnson. I'm Joe School of Medicine at UT in Austin. And the question I have is, I see a lot of people being discharged from the hospital to the streets, and I also see a lot that need to be in a hospice type situation, but I'm not seeing those anywhere. So how do we look at finding funding, restructuring funding in order for that to happen?
Well, I think it depends on your community. I think that we could probably meet afterward to have some type of strategy. But I think a lot of the stuff that we stated, just like telling the story and starting collecting those data of the patients that you do see that are discharged. But it is a hard topic because it does happen often. And also even ones, like I said, that need to go to hospice care, what a lot of times it's something to do with their insurance, or so having that advocate that there with the patient as it happens sometimes is the way to do it. But I do feel like it's a strategy that you'll probably need to have data behind if you want to go to the hospital. But you want to say anything? Right.
I would just say that make sure you're tapping into their case manager that may come with their benefit, because that's going to help you get where you need to be a lot faster. Don't put all that pressure on you or your staff. Utilize their resources as well.
I hear you in that, but I'm always that phone call. I'm always the one getting that phone call. Hey, we're discharging Bill Smith to the street. He has testicular cancer, fourth stage, had whatever surgery, and he's going to the streets. Do you have a tent?
Oh, yeah.
Do you have a sleeping bag?
I just want to comment on that briefly. This is coming up a lot in respite care right now, end-of-life care, palliative care.
And we have
Weekly, it's coming up on our TA calls. So the council is going to be doing some work around this later this year. We have one of our breakout groups this afternoon is focused on hospice care. Some respite programs are moving towards doing hospice care. Some programs are saying absolutely not. That's not the business we're in. And it's very complicated. So I think this is a trend that's going up in medical respite care. The
so
need for more palliative and end-of-life care.
Yeah. And I think there's different ways to do it, especially if home health or someone can come and actually do the hospice care on site in the shelter. There's a lot of different creative ways, but it really depends also where your shelter beds are, if they allow that.
So Travis County, we have 20.
That's not bad.
Yeah.
So Ashley with Common Spirit Health. I think one of the things that we are trying to do from a health system is also educate our hospitals that recuperative medical respite is one of the continuum.
Yeah.
And so when we're talking about all these other opportunities, what we're trying to say in the community is medical respite is not able to serve everyone. And so that's kind of a learning for our hospitals, because it really is one of the unique locations that we feel safe for the individuals to go. But our social workers are so, passionate that they want to find placement, and so they do go to those that they know best.
Yes.
But I think that's one of the things as we talk about hospital relationships is for us to make sure our internal staff recognizes medical respite is for a certain population and not for everyone being discharged from the hospital.
And I think you have to do quarterly education on that. I'll just say from case management point of view, just because you do have a lot of transition, and sometimes people will just forget. But also, I do now these sort of housing workshops where I show them the whole entire flow for the COC and also tell them what permanent supportive housing is. But also you don't want the respite to become that dumping ground when they actually need to go to a nursing facility. So educating the social workers that they actually need this care, a higher level of care, and sometimes you have to go on site to see those patients and tell them, no, they don't need to come to respite, they need to go into a SNF, because a lot of times you are that advocate for them while they're in the bed.
Thank you, everyone. I see all your hands. We are out of time, but we will have a breakout session this afternoon focused on hospital partnerships, so please join that conversation. We're coming up on a break fairly soon, so if you want to chat with Brookesanne or Lori during the break, please feel free to. Thank you, Brookesanne and Lori. Really
Thank y'all.
appreciate
Y'all
it.
are awesome.
So I'd like to bring up Barbara DiPietro. Barbara DiPietro is the Senior Director of Policy for the National Healthcare for the Homeless Council. I referenced her earlier. She's got red hair. Barbara does, what does that mean? Barbara does a lot of work around all homelessness and healthcare policy work, but Barbara really does a lot of work around medical respite care and policy. And she's going to talk today about some additional funding opportunities for respite. Thank you, Barbara.
All right, great. Hello, everybody. I have no slides, so Q&A is my presentation. So want to just talk a little bit, hospitals, yes, critically important, major funding source, but they're not the only funding game in town. So my job here today, I've just got 15 minutes, so this is just a quick snapshot to talk briefly about 3 other funding sources that you should be considering for your medical respite program. Health centers, managed care plans, and state-level Medicaid funding. So let's start health centers. How many people here are coming from a health center? All right, awesome. Okay, so I'm gonna have to use glasses. You ever get to a point in your life where you can't read anymore? Okay, it's terrible. So health centers, recuperative care is very clearly an allowable service for health centers. Health centers also bring the broader range of needed services and service providers. They allow the FQHC reimbursement for billable care, and medical respite clearly improves patient care and outcomes. Oftentimes, the patients that are in medical respites, the clients that are getting those services, are the same clients that we're seeing at the health center. And so all of these outcomes are related. Helpfully, we have a policy brief on this. It outlines the advantages and the challenges of integrating a medical respite program into your health center. It aligns with the components, it aligns the components of medical respite care with HRSA's Health Center Compliance Manual, a fine piece of literature if you have never really spent time with it. And it also offers 10 action steps for moving forward. So for health centers, really recommend this. I think we're sending a resource piece out afterwards. We'll line up all of this if you don't already have it. So health centers, absolutely fantastic partner. Number 2, managed care plans. Curious, anybody here from a managed care plan? All right, excellent, good, good. Okay, so individual Medicaid managed care plans are partners in this too. Clearly, they care about the spending and the lower cost that medical respite offers, clearly. But managed care plans also care about and are evaluated on quality outcomes as well. So when we look at readmission rates, engagement with primary care, chronic disease management, follow-up care from hospitalizations, transitions in care, all of these are quality measures that individual managed care plans are evaluated to as well. This is why more and more MCOs are negotiating individual rates with respite programs in order to pay for those services. Helpfully, we have a policy brief on that too. So our policy brief here describes 7 examples of medical respite programs that have negotiated individual rates with their MCO partners, and we include those and what services are included in that reimbursement. We also have an 8 principles of reimbursement document to help you with those negotiations. One of the biggest pieces that for me is don't shortchange yourself. Don't come at this from a poverty mentality of, oh, pretty please, can I have $100 per diem for the broad range of services I'm doing? No, ask what you need to pay for the care that you're delivering. So let's talk about state-level Medicaid. Anybody here coming from state health departments? All right, great, excellent. This is where things are starting to get juicy, and it's where all the policy action is. So right now we're tracking 12 states that are in some process of either getting or implementing a statewide Medicaid benefit for medical respite care. Julia talked about a few of those examples earlier. A statewide benefit is where you're going to get the most sustainable funding. And it's not based on the individual negotiations with each plan, right? Because many of you are probably working with 3, 4, maybe upwards of 7 or 8 plans. To negotiate something different with every single one of them is an administrative headache and inefficient. Obviously, we can talk about the inefficiencies of the American healthcare system, but that is a wholly different topic. Okay, different workshop. One of the things, too, with talking about a Medicaid statewide benefit is that this elevates the discussion of how the housing crisis in this country is backing up and dumping into the healthcare system. And that's got to be a discussion. It's got to be a discussion that talk about the opportunity for housing funding. And so states need to reckon with this. They illustrate how the injustice of the housing crisis has become our problem to solve. Medical respite shouldn't be necessary in a just society. But here we are. Helpfully, tomorrow we have a workshop on this very specific topic, tomorrow at 3:45. We will hear from programs in 3 states. California, who's already implementing a statewide benefit, and then also Washington and New Mexico, who are in the process of starting implementation. So that's your teaser. Please join us tomorrow afternoon for that discussion. So all of this is to say, you've got options for how you fund your medical respite program. And so much of this is going to depend on your individual state, the dynamics of your community, your partnerships, and frankly, your sweat equity and what you're willing to put into it. We're in an environment where HHS is encouraging us to think broadly, encouraging states specifically to think broadly about how to use Medicaid to address health-related social needs. Obviously, like the lack of housing. So if you remember 8 years ago, CMS issued guidance on how to use Medicaid to put tenancy supports into your plan. And that fueled a huge growth of services and supportive housing. Just 2 years ago, CMS updated that guidance and broadened it, really encouraging a broader application of social determinants of health within Medicaid. So we've got the green light from the federal government. It's just how states want to use that flexibility. Now, none of these funding sources, not hospitals, not health centers, not plans, not statewide Medicaid, come without challenges. So let's be clear. But that's why NIMARC was established, to help you navigate a rapidly changing environment. So the rest of today is focused on program operations, delivery of care, but we started today with a funding discussion because that's what's going to drive the work. The reimbursement and the resources you get from these funding sources are going to dictate the staffing, the services, the reimbursement, like all of it. So that's part of why we just wanted to do this just taster of other funding sources that you might consider. But finally, as policy director, I'm compelled to say that there's a broader context to our work right now. If you're in this room, you're not just part of a medical respite community. It's important to acknowledge the values that are driving this work. And if you are in this room, you are part of something bigger in this country. If you are in this room, you are part of a larger movement that is centering the values of dignity and respect and compassion and justice. Now, I don't know if you've heard, but there is a widespread and concerted effort in this country to take health care away from people. housing away from people, food away from people, civil rights away from people. Encampments are being swept across this country without any regard to the people that live there or their health or well-being. Black men continue to be lynched in this country in public. Jordan Neely's killer is called a hero. And that ain't right. What we're seeing in this country isn't right. And it feels like we are currently in a battle for the soul of this country and who deserves health care specifically. So make no mistake, this is a battle for the moral values that are going to dictate who our society is now and who we will become. And if you are in this room, I just want to offer 2 points. That your work and your voice and your advocacy in this battle is important, and that if you are in this room, you are part of a community that cares, you are a community that is committed, and you are a community here, and let's try to find joy in the struggle for justice together. I will leave you with that. And I'll see you tomorrow afternoon at our workshop. Thank you.
Thank you. Right. Yeah. What sign is Barbara? Fire. Thank you, everybody. We have a third, on that note, the soul of the country. Let's take a break, get a little treat, get some coffee, rehydrate. We'll be back here in 30 minutes at 10:30. Thank you.